Now, these are my disclosures. Now, as you well know, enteroscopy is mainly based so far on device-assisted techniques. Double balloon enteroscopy was introduced by Yamamoto in 2002, later on followed by single balloon enteroscopy and balloon-guided enteroscopy, which has not gained wide acceptance, and spiral enteroscopy. Spiral enteroscopy has been mainly used in the United States, but also in Europe and in Asia. It's based on a Discovery SB overtube, which is 180 centimeter long. And it has an implemented spiral, 21 centimeter in length, and it's compatible with Olympus and Fujifilm enteroscopes. In principle, a second endoscopist rotates the tube with a spiral, and the aim is to pleat the small bowel onto the tube and to shorten the small bowel to allow deep penetration. A systematic review and meta-analysis published a few years ago included 8 studies, more than 600 procedures, and it showed no significant differences between balloon and spiral-assisted enteroscopy in terms of diagnostic and therapeutic success rates, depth of maximal insertion, rate of complete enteroscopy, and rate of adverse events. However, the procedural time was significantly shorter for spiral enteroscopy. Olympus acquired the company which developed the SB overtube and developed a motorized technology for motorizing the driving of the spiral with the aim to simplify the procedure and still allowing to do enteroscopy with standard endoscopic skills to eliminate the overtube by integration of the spiral, which may reduce complications and achieve greater depth of insertion and retain superior speed and control, which is the main advantage of the spiral-based techniques. The so-called power spiral enteroscopy system is based on a reusable endoscope with an integrated motor for rotating a short spiral overtube component mounted on the insertion tube portion of the endoscope, a motor control unit with foot pedals and a visual force gauge, and a disposable spiral overtube component. And this slide shows some details. So the endoscope itself, it's comparable to a pediatric colonoscope, 168 centimeter in length, 11.3 millimeter in diameter, and very important, it has a 3.2 millimeter working channel so that we can do any kind of interventions as we do for colonoscopy. The spiral has a length of 240 millimeters, and it's with this distal end 16 centimeter above the distal end of the special enteroscope. So we did the first clinical case in November 2015 in our hospital, and we gained wide experience with this technique. So this is a live video from a demonstration in the endoscopy course in Rome. So here we can see the system with the integrated motor, and this is the spiral, and as you can see, very soft with flexible soft fins, and with a foot switch we can rotate the spiral counterclockwise or clockwise, so not the endoscope is rotating but only the spiral. And we have an acoustic and visual force gauge showing the resistance when we drive the spiral. And when we squeeze now the spiral, we see a higher resistance with an automatic shut-off when we are above a certain threshold. Now, this is the insertion now into the esophagus, and this is a disruptive technology because for the first time, we don't push the endoscope or just supporting the advancement, but it's mainly done by rotating the spiral, meaning it's pleating the small bowel onto the shaft of the endoscopes, and in a good position we can achieve a deep penetration into the small bowel in a short time. So we initiated a prospective bicentric non-controlled clinical trial together with a group in Brussels with Jacques Devier and his team, with the main aim to evaluate the diagnostic and therapeutic yield and the safety of paraspiral enteroscopy in patients with suspected small bowel diseases, and to demonstrate that the diagnostic yield is not inferior to single or double balloon enteroscopy. So primary objective, diagnostic yield, and secondary objective, success, procedural time, depth of maximal insertion, therapeutic yield, and adverse events. And the inclusion criteria are quite similar to other studies on enteroscopy. Mainly, patients were enrolled with overt or obscure GI bleeding or iron deficiency anemia, but also chronic diarrhea, suspicion, and Crohn's, and other diseases suspicious for pathology of the small bowel. In terms of exclusion, we did not include in particular patients with any prior gastric, small bowel, or colonic surgery in this first study and first evaluation of paraspiral enteroscopy. So the trial was just published in Gut. We finally included 132 patients who underwent 140 procedures, and the data show that about half of the patients had ASA 3, so we had a couple of patients with comorbidities. Indications were mainly seen in patients with suspected mid-GI bleeding, 98, pure IDE 17, and others 40. And 96% of the patients had positive findings in video capsule endoscopy, which was routinely done before enteroscopy. Technical success rate was 97%. This was defined as a passage of the enteroscope beyond the level of ligament trites. Median insertion time, 2 ligament trites, 3 minutes, between 1 and 25. From ligament trites to the deepest point, 25 minutes on average. Median procedure time, approximately 1 hour. And median insertion depth beyond trites, 450 centimeters. This is, as we know, very difficult to measure for any type of enteroscopy. But the fact that we approached the cecum, so achieved the total enteroscopy in 11% of the cases, indicates a deep penetration, although this was not the primary goal to reach the cecum in all cases. And the operators voted on the mean ease of use. So 1 is very easy, 5 difficult, and 2.0 means in most of the cases it was relatively easy to perform PSE. So the diagnostic yield was 74%. This was a primary objective, so higher as compared to other techniques on enteroscopy. 55% at AVMs, inflammatory lesions 15%, polyps and neoplastics 17%, tissue sampling in approximately every 4th patient, and these were relevant for further treatment in 67%. We did interventions in 102 cases, in particular APC 69 injection, clip placement, EMR polypectomy, and some others. They always succeeded, and the therapeutic yield was finally 68%. And this is an example here, again in the live demonstration in Italy, patient with Peutz-Jeghers syndrome. So we are in the distal part of the jejunum, and as you can see, we have a very stable position, and in between we can go forth and back to reposition the scope. We have a 3.2 millimeter working channel so that we can use regular devices because the system is just 160 centimeter long. and we can remove the polyp, can place clips, and therefore this explained the high therapeutic success rates. We observed anticipated non-serious adverse events in 14%, for example, abdominal pain, no severe complications. These were observed in 2 patients, one with a delayed small perforation in the terminal ileum and 1 patient with a delayed bleeding at the EG junction. Following this trial, we initiated another series, again in these 2 centers, Brussels and Düsseldorf, to achieve a total enteroscopy with a primary objective to achieve a complete antegrade approach or a combined antegrade and retrograde approach with the same secondary objectives as I mentioned for the first trial. And we had also the same inclusion and exclusion criteria, but in these patients, there were indications for total enteroscopy. So we started with an antegrade approach under general anesthesia with the intention to reach the cecum. And if this did not succeed, then we continued with submucosal ink dye injection at the deepest point of insertion, followed by a retrograde approach just under deep sedation for failures on complete antegrade PSI on the following day with the aim to identify the ink marker in the small bowel. We enrolled 30 patients, technical success 100%, complete enteroscopy in total 70%, but an antegrade approach only in 17%, combined approach 53%, and the mean insertion time for the antegrade route 32 minutes, retrograde 22, diagnostic and therapeutic yield quite high, comparable to the first trial, and non-serious adverse events in 17%. So this trial has just been accepted by GI endoscopy and will be published very soon. And finally, we also started to evaluate this technology in patients with altered GI anatomy in whom there were indications for ESCP. So far, we enrolled 17 patients and all of them had a Roux-en-Y anatomy, 10 of them biliodigestive anastomosis, indications biliary strictures, 9 cases stone, 6 and others 2. And the results show that the procedure could be done under deep sedation without general anesthesia, and the papillar or biliodigestive anastomosis could be approached in 82%. Biliary cannulation succeeded in 71%, followed by successful interventions. The rate of adverse events 6%. So also very promising results in this first feasibility trial. And this is a short video here in a patient with a biliodigestive anastomosis and strictures of the right and the anastomosis to the right and the left hepatic duct. So after passage of the stomach, we are now here in the duodenum. And again, is a little bit pushing, but otherwise pleating the small bowel on the shaft of the enteroscope. And now we are in the distal part of the small bowel, entering here the hepatobiliary limb. And finally approaching the anastomosis. And again, this is the advantage here, as I've mentioned before, that we can use standard ESCP accessory devices because the instrument is only 160 centimeter long, and we did balloon dilatation, and the same was done then on the right side. So I would like to conclude, this is a disruptive technology. The first active endoscope is promising as a novel, effective and safe diagnostic and therapeutic approach to the small bowel. It's applicable with standard endoscopic skill. The learning curve is relatively short. short procedural duration, and ease of interventions, which is quite comparable to colonoscopy. So thank you very much for your kind attention, and I'm happy to answer questions. Thank you.